Kia ora. I'm Marilyn Head from the New Zealand Nurses Organisation, and thank you very much for that comprehensive look at migration. My question is to Sue, because we face a very similar situation in New Zealand with an over-reliance on internationally trained professionals, but we also have the problem of nursing unemployment, and I wondered if you had any ideas of how to kind of shift the discourse away from, jobs for our girls sort of thing, to the more important issues about self-sustainability and, the imperative to actually not contribute to the brain drain, but to actually do something actively about supporting the health needs of poorer countries.
Thank you very much for your question, and I'm so glad that my trade union comrades are here, and I hope we hear more from you in this panel discussion. I'm really glad you put it in the context of the global anti-migration sentiment, and this is where I think we are at the sharp end of globalisation. Globalisation can decrease inequalities between countries. It can help lift countries out of poverty, but we know within countries that it can actually increase inequality. And so when you're getting unemployment in wealthy countries like New Zealand or Australia, or precarious work or underemployment, such as in nurses in New Zealand, that's when people are vulnerable to these fear and scare campaigns by the Brexit campaigners, the Donald Trumps, the Pauline Hansons of the world. And so I'm really glad you've located this panel discussion in that conflict zone, I suppose. One of the responses, of course, is to be more conscious of our shared humanity. And as an academic and a teacher of health professionals, I do try to instill that shared understanding and humanity in my students and a global perspective. Closer to home, I think we do need to pay more attention to issues of retention of our health workforce. I think there's some inhumanity amongst employers and managers of health professionals, and I hear the metaphor of turning on and turning off the tap. And when I hear very senior health service managers talking about other human beings like their water coming out of a tap, I get really concerned at that sort of objectifying language. So at the local level, I think we need to be more humane in a human capital sense towards people. And at the national level, certainly my research in Australia, in terms of coming more to the crux of your question, is very simply that the departments actually need to talk to each other and coordinate their policies. And they actually don't do that now, currently, anywhere near what we would expect them to do. So the education department's educating all these health professionals for the future, and then the immigration department increases opportunities for migrants to come to the country, particularly skilled migrants, and the two aren't necessarily talking to each other. So very concretely, I guess my most concrete response to your question is that the actual departments of health, education and immigration need to be better coordinated.
Thank you, Stephanie. Are there any further comments? Mark, I'm not sure if you would like to make a comment.
I'm sorry, I didn't catch the question, only the answer.
Okay. Well, I guess, would you like to paraphrase?
Oh, yes, the question from our colleague from the Nurses Trade Union in New Zealand was, we've got unemployment of professional nurses in New Zealand, and we're still encouraging migrant nurses into New Zealand. So how do we deal with the conflict and the tension between the locally trained nurses and the immigrant nurses? And how do we avoid the rhetoric or the discourse or the language of, employ our own and therefore treat the migrants as second-rate or second-class workers?
Thank you, Stephanie.
Well, I just have a couple comments. One, I think if you look historically, there has been prejudice and bias against immigrants for hundreds of years, certainly in this country and elsewhere. So it's not a new phenomenon. And part of what I feel strongly about is we need to humanize migration, to put it in a context, to have people understand it's a normal phenomenon and it's not some aberration. In terms of the nursing situation, I would just say that, you know, each industry has its own demographic reality. So, for example, in agriculture in the United States now, there are crops that are not going to be planted or harvested because there's no workforce. And the idea that there are native born who are going to do that work is a complete fallacy.
Thank you. Okay. Are there any further questions? Thank you.
Thank you very much. Ifat Al-Barazi from United Arab Emirates University. Okay.
Thank you.
Just my question, I think, to Dr. Allison regarding the, you pointed out that language difficulty could be one problem in terms of exposing migrants to some toxic substances. What about discrimination?
Absolutely, yes. And I haven't talked about that here, but among those same ethnic groups, we then did another study looking at bullying, racism, discrimination, precarious work. We're still analysing the data, but racism is certainly coming out, and it seems to work at 3 levels in the labour force. So first of all, you're limited to the industry that you can work in because of racism. And then if you have a job, you might be limited from promotion or equal opportunity or anything like that in a particular organisation. And then at the third structure, you might be limited because of your relationship with your colleagues or your supervisors and things. So racism works, you know, at the level of the market, the job, and your sort of personal interactions. Absolutely. You know, I think, yeah, the Arabic workers seem to be doing the dirty tasks in the same job. So, yeah.
And this brings us also to the point of the refugees who are coming to Australia from different, now with the Syrian conflict. I think we're facing really very bad, I think what will happen is going to be worse if we don't really change our politics again, because with the migration and the refugee policies in Australia are going, I think, opposite to the refugees' rights. I think this is something that we might need to really work on in Australia.
What we found from some other work, and this wasn't Syrians in particular, it was people that just arrived in Australia on a humanitarian visa, and it was some focus group, sort of qualitative work, but they had very little understanding of their work rights and conditions, very little understanding of their entitlements. They thought that $10 an hour was really good because in Burma they'd be paid $1 an hour. So they really need to be educated when they come here about what is a good job and what they should expect at work, and otherwise the exploitation could be really rampant.
Thank you very much.
Thank you.
May I comment?
Oh, yes, please do.
Thank you for that question and for bringing our attention to these concerns around bullying and prejudice and discrimination and so on. Unfortunately, we've seen prejudice and bullying experienced by international students in Australia who have the right to work up to 20 hours a week. And we've even seen Indian students be the subject of violence in Melbourne, for example. And the pointy end of that conflict was the local workers felt that the immigrant workers, or in this case the temporary workers, the students, were undercutting their wages and conditions. So that's something that's very, very concrete and a cause of serious concern and consideration in terms of how we can, again, humanise those relations and improve the wages and conditions of temporary workers or migrants or refugees so that we're not creating that tension and conflict.
I would add to that the economic analyses do not show that the immigrants, lower wages. In fact, they increase them for the native population. And I think part of our task is to get out the research and the data, including economic analyses, to counteract what is, representation.
Thank you, Mark. Colin?
Thanks. Colleen Fisher from the University of Western Australia. I guess my question brings together some of the strands that we've been talking about in the other questions. We've heard about the three Ds and the three Cs, and I guess my question is about, okay, how are we actually responding to this? Who's active in the space, and particularly, is there a role for unions to be involved? I guess I'm not just talking about some of the like construction unions and things like that, but even related unions like health professionals and things like that. So my question, I guess, is there a role for unions? Are they active? Should they be engaged? How could we engage them?
Thank you, Colleen. Anyone? Stand silent.
In designing these projects, I've spoken to a lot of trade unionists and presented the results to trade unionists, but I don't know what's actually happening on the coalface in terms of this. I know that they're aware of the problem, but I think a lot of migrant workers may be reluctant to join trade unions or to participate in trade unions, and that might be from their experiences of oppression or whatever in their own country. I don't know, is there someone here that can tell us about the perspective from a trade union point of view?
Could you just for Mark, he won't hear you unless you speak into a mic. Thank you. Well, and everyone else.
Speak from the Council of Trade Unions in New Zealand, where the late, great Helen Kelly, who passed away sadly last year, was an absolutely passionate supporter for migrant and agricultural workers' rights, etc. And whether or not they belong to the union, and we don't have an award system like you have. In fact, we have nothing in New Zealand except the small percentage that are covered by unions. But the Council of Trade Union is almost alone, I think, in this space and working with a few migrant NGOs, but they are a voice for temporary workers, for migrant workers, and particularly for agricultural workers coming. Can I take this opportunity to also challenge Mark about his statement that migrant workers don't undercut wages and conditions. They certainly have in New Zealand in the aged care sector. A large proportion, nearly 50% of overseas internationally trained nurses, mainly from the Philippines, go to work in aged care, and the average wage in aged care for nurses is considerably below the starting rate for nurses in hospitals. That's a direct example where migration. Aged care, I should say, is mainly privatised and the hospitals are public hospitals. So that's a direct, a particular example of where migrant wages have actually undercut wages and conditions in the country.
Let me just clarify. What I meant to say is that wages paid to migrants are not reducing the wages paid to the native born. They are clearly being paid less, and they're usually doing jobs that no one else will do, although that may not be the case in nursing, I don't know. But what I was talking about is not the migrant wages, I'm talking about the impact on native-born women.
Okay, so maybe we'll have the question at the back and then yourself.
May I comment on that too while the person's coming to the microphone? Oh, you're at the microphone. I think we need to be looking at the employers here. I mean, it's great to look at the responsibility of trade unions and even political parties like the Labor Party in Australia or in New Zealand who seek to represent the interests of workers. But it's the employers who are recruiting these workers who can undercut the pay and conditions that would otherwise be enjoyed. And it's the governments who choose policies to respond to the demands of employers to do this. So I think we should be putting the responsibility back where it rests with the employers who want to underpay these people or pay them the lowest possible rate more precisely, and the governments who support the immigration policies to open up to workers who are going to work for less. So I think we should be moving upstream, is that upstream? To use the metaphor, the public health metaphor. We should be moving upstream to the employers who are driving immigration policies. Governments respond to the immigration policies, and then the professions follow, or the trade unions in this case follow. Thank you.
Thank you. Have your
Hi,
question.
Ty McMahon from SSI in Sydney. We're a non-government organisation working in the migration area, providing refugee resettlement and some other programs. My question is for Alison. There was a bit of a contrast between what you were presenting and what Mark presented. Very stark differences between migrants in terms of their occupational health outcomes in the US by comparison to here in Australia. And I think you said or intimated that the evidence base in Australia is that migrants aren't doing that badly in terms of their occupational health outcomes. I wonder to what extent that reflects or might reflect the methods used to assess how migrants are faring. I notice and congratulate you on your study of actually allowing people to use their preferred language to describe the risks that they're experiencing in the workplace, and to what extent our local evidence base is essentially excludes people who might, in fact, not be participating in research.
Absolutely. So I've looked at work-related injuries from a survey by the Australian Bureau of Statistics. That was a self-reported survey, and to be included in that survey, you have to be, selected. So I think certainly there would be under-selection of migrants in that, and so that may then have reflected the lower reporting of work-related injuries in migrants compared to Australian-born. But another study I did looked at hospital admission rates that were paid for by compensation, and I looked at country of birth, comparing various country of birth groups and Australian-born groups, and also death from a work-related injury by country of birth. And it was the deaths in particular that we didn't find, apart from New Zealanders, we didn't find any excess mortality by country of birth compared with Australian-born, apart from New Zealand workers. So in New Zealand, they have a higher work-related injury rate than Australia, and it seems that they're bringing their excess risk with them. And that's the only reason that I find that we have a difference with Mark, is that I don't see how you can make a mistake on a death certificate. There couldn't have been any misclassification by country of birth or something like that. So that's my only strong evidence, but certainly for self-reported surveys and Australian Bureau of Statistics surveys, those workers may well not be included in those surveys, and so that explains the underreporting. Particularly when you think about horticulture here and who is working in our market gardens, and it's all this now, 417, the working holiday workers. So, I suspect that there are injuries and things happening, and then they're either not being reported or not being counted, or I think certainly there must be some undercounting and misclassification going. But just the deaths, there wasn't a difference in the deaths, that sort of worries me. It doesn't worry me, that's just, I can't explain it,
Comment in relation to the 417, to the working holiday visas in Australia. That visa is largely granted to high-income countries. It's not granted to low and middle-income countries. Sorry, I'm Irish-born, I know what I'm talking about.
Okay, yeah.
Okay.
And I came to Australia as a working holiday visa in 1987.
still here. Okay. Thank you for your question.
My name is Howe. I work with refugees in Melbourne. My question relates to this issue of normalisation in health services, because I think we're here talking about migrant health because migrant health is an issue, but the complementary thought is, well, what if we get to a stage in health services where migrant health is not an issue, where it's just health? And so my question relates to how can we move health services and systems forward to normalise migrant issues, for example, so that the use of an interpreter isn't an afterthought or a burden, but it's something done for migrants or people who need Auslan or Aboriginal interpreters, for example. How do we move forward with, say, health education in health systems, whereby instead of seeing it as a burden to educate migrants about how to use the health system, that it's part of it, and that could be applied even to people with intellectual disability or young adults or something like that. So I'm just wondering, how can we move the whole health system to normalise dealing with migrants and other groups as well?
Stephanie, is that one for you, do you think?
It sounds like, may I throw it back to you? It sounds like you, I missed which organisation you're with. Are you with an organisation that's doing that making progress in that area?
Through a number of organisations, yes.
And
yeah.
would you like to elaborate on that?
Oh, I'm keen to hear your views, but no, I mean, some of our approaches have been working directly with refugee communities, with refugees teaching other refugees about how to access health services.
Mm-hmm.
Some relates to advocating for access policies that are equal and relevant to people without, Medicare access, for example. And some relates to upskilling the health workforce to better deal with refugees. But my question goes, while those approaches are very targeted and time limited in terms of funding, and we can do that with right now, but in terms of moving the whole system forward to be able to deal with this, that's where I'm going.
Mm-hmm. Thank you. Well, I guess coming from the women's movement, we know that when women are represented in a critical mass, particularly in management levels, then organisations become more responsive to women in this case. Being a fourth generation migrant and part of the Anglo-Celtic majority in Australia, I can see that our student body is changing at the University of Sydney. The students that I'm teaching week by week are much more ethnically diverse than they were even 10 years ago. We've got a lot of migrant students, a lot of first generation Australian students from a wide range of backgrounds in my tutorials: Arabic speaking, Chinese speaking, Vietnamese speaking, African background students. So by force of numbers and so on, that's going to be one progressive change, that the health workforce itself is becoming, and the health professional workforce is becoming more diverse. But of course we need to be, active and proactive about, anti-discrimination policies and culturally appropriate services, interpreter services, and, as you say, making it mainstream to be responsive to the diverse community.
I think it's a very good question addressing primary health care, which is really what we want for everyone. And I feel like I'm living in another world here, because in the United States, we have 12 million undocumented immigrants in the country. In California agriculture, 50 to 60% of the workers are undocumented. And for that population, things have really become critical in terms of fears of deportation. If you present for, regular health services or any type of government assistance or any program. And so it's really a bit of a crisis at this time, with stories coming from everywhere about immigration raids and people being deported. It's hard to even think about primary health care in that setting when people are dealing with, their livelihood. But that's the reality that we're seeing now, particularly since the election.
So I guess that is the elephant in the room, isn't it, Mark? So What do you see the future in the US, particularly with environmental regulation being diminished, funding for health research, etc.? So do you want to comment on Trump's new era?
Do I have to? It's a crisis in so many ways, in all the things that I believe in, and we need to push back where we can, and California is the one bright spot in the country. Where we have legislation now to make it a sanctuary state that may be passed. The one thing I can say is that immigrant workers are critical to so many economic sectors, and when that factor is filtered in, perhaps some of these proposed policies will change. But we're very depressed here.
Okay, we have a question at the back.
Hi, I'm Celia McMichael from the University of Melbourne. This represents a bit of a shift in focus maybe, just to bring up the theme of climate change and migration and health. So it was a really interesting presentation. What I was hearing was you talking about the links between the way climate change might drive or contribute to migration and what the health outcomes for those people might be. But I think another important thing to think about is what the health of migrants will be generally in a warming world. And it relates to the point Mark was making, where you're getting, say, migrant workers in doing so-called low-skilled work or agricultural work and outdoor work, where we're possibly looking at temperatures increasing of, say, 1 to 4 degrees in coming decades. So I think that's another layer, and I'd be interested to hear your comments on that.
Yes, thank you very much, Celia. And I know you've done work yourself in this space of climate change and migration, so I'd like to acknowledge that. Clearly, there is an impact of climate change on the health of all of us, regardless of where we are. And I think the work that Mark and Alison have done really shows that potentially migrants can be more potentially exposed in the countries where they end up to these climate change risks because of the nature of the work that they do, and potentially also their socioeconomic, relative socioeconomic deprivation, if you like. Deprivation is not quite the right word, disadvantage. And so, I could talk all day about the impacts of climate change on health, but I won't. And you've raised one, and Mark raised one in relation to heat. It's worth recognising that there are many. And my area of interest in climate change and health has been largely at the impact of climate change on our human systems and on our economies and so on, which I think ultimately will, and our food systems and water, which ultimately will have a much greater impact on all of our health. And this is where countries which are potentially the source of climate change migrants are coming from. But increasingly we will be experiencing that wherever we are, and even in relatively wealthy countries such as our own. And I think, I spoke yesterday, I mentioned Cyclone Debbie and how already it's been forecast that we even within the space of a month, that's going to have an impact on our vegetable prices across Australia because of the loss of vegetables from that area, and we saw that previously with Cyclone Yassi. And those of us most of us probably sitting in this room, at least the Australians, will be able to respond to that by spending a greater part of our disposable income on those foods. But I know during the Millennium Drought, at that time I was working for Queensland Health, and we were responsible for the Go for 2 and 5 campaign, trying to encourage the increased uptake of fruit and veg. And we actually did see an increase of up to 1 serve as a result of that campaign, that then reversed following the impact of the Millennium Drought, which we know was climate change, or at least exacerbated. And that drop then was related, further work showed that that drop was related to the increased cost of fruit and veg. So I think, that socioeconomic disparity and many migrants, not all, falling into that lower area then make them much more vulnerable than the rest of us to some of those climate change impacts.
Yes.
Jane, maybe Linda and Celia, who is active in this space? It was a question raised earlier in the context of the health workforce, but in the context of climate change and global warming and its effects on people and our ability to support ourselves, our livelihoods and our environments, who is active in this space? Where is the human agency? Who are the groups or the groups or the parties that are actually active in this space to respond constructively to these challenges or problems?
Do you mean the adaptation challenges?
Yes. I mean, is it Greenpeace or the Sea Shepherd, or who are we looking to for political action in this space?
Well, I think we have to look to all of us, and I guess that's why not all of my climate change advocacy, but quite a lot of it I try and do in the context of being a health professional, because, when I talk on behalf of Greenpeace, or when I used to, then I'm Greenpeace, and it's easy to be written off as, well, you're just Greenpeace, and, we know that, you've got these other agendas. But when healthcare workers play that advocacy role, it can be much more powerful. And I feel like in a way I'm potentially tainted because of my background in terms of that, the association. But there are many people in this room and many people who aren't in this room who don't have those potentially considered negative connotations, who can play a really key role here. And that's why I think that increasing discussion about climate change and health is important from the perspective of understanding the impacts and preparing for them, because they're going to increase, as I said before, regardless of what we do in mitigation. But to me, even more important is our role as advocates, and the greater understanding we have about those impacts means that we can be more effective in that advocacy. So I'd say all of us. If you're wondering who to align with, then I think you can do it within our own institutions. For example, I and others have been trying to activate the College of Physicians more, but there is the Climate and Health Alliance, and Fiona Armstrong's here. There's plenty of Doctors for the Environment, of which I'm also a member. There's plenty of opportunities to be involved, and even our PHAA as well is active. But I just encourage everybody to think about how you can be involved in this advocacy. It doesn't have to be necessarily at the front line, but there's a lot that can be done in terms of supporting and speaking out when the opportunity arises. I also can I just say one more thing? Sorry, I just while I'm on my hobby horse. Fiona Armstrong from Climate and Health Alliance mentioned to me that they're about to undertake some training for health practitioners to assist in terms of doing advocacy around climate change and health. And one of the things that they're going to do is to have a health practitioner in each federal electorate adopt their local member and build a mentoring relationship so that they can understand that relationship. And I think that's a really fantastic, powerful innovation.
I'd like to second those comments and to just say that in academia, advocacy does have some role. It's not the primary role, but you have a lot of credibility, and to be able to carry the research to the political world is appropriate to affect the changes that you're studying. So unfortunately, that's not a belief held by a lot of academics, and it's not often rewarded. But I think there is enormous potential in outreach and engagement by academics.
Yeah. Okay. And thank you for your patience at the back there.
Sure. Good evening. My name is Grace Nelson Odima. I am from the United States, Central Michigan University. And I have 2 questions to ask. First one is, how do we encourage the immigrants to report injuries without fear of being deported? And that's the first question. And the second question is, what coding system do you use when they incur or when they have the occupational injuries? In the US, we used to use an ICD code book 9. Now we're using ICD code 10. So what do you use as far as immigrants in order to code those occupational injuries that they acquire?
To answer your second question first, we use the same here. And I was looking at data from 1980 to 2010, and so I had to use ICD volume 8, 9 and 10, I think. But yes, we use exactly the same codes, so that wasn't the answer. And the immigrants were coded no differently than the Australian, so.
Okay.
As to your first question, that might be better from you, Mark, because we have about 60,000 overstayers in Australia, so we don't have the same issue with undocumented workers as you do in the US.
Well, it's a very real issue, and I don't have a simple answer. Not only does the immigrant worker know that if they report an injury, they're at risk of losing their job or being deported, but often the employer is encouraging the worker not to report or to report that it was not work-related because the workers' compensation rates are set by the injury experience of the employer. So they want to keep their rate as low as possible. Further, we know in this country that serious disabling injuries often lead to workers leaving the country because they can't get chronic care. So I don't have a simple answer except to say that it's a huge problem and one needs to focus on that to do what we can.
Can I follow up, Alison? So there would be underreporting, though, in Australia.
I'm sure, and I think maybe one reason why I might not have found differences in admission for a work-related injury to hospital was because the definition was the hospital admission had to be paid for by workers' compensation. So if you don't know about the workers' compensation scheme, or if you don't know it, you therefore might be excluded from it, or your process might start delayed. And so that's another means of underreporting and misclassification. Absolutely. In theory, it shouldn't happen, but I think there's even been some work in New South Wales to show that it has happened, and that people with a migrant surname were less likely to have received compensation than those with a more anglicised surname.
Can I ask you a question? Have there been a response from WorkSafe or Safe Work about in terms of the results that you've found? So what are the actions that are coming out of it, I guess, in terms of public policy?
Safe Work are very interested, but they're a federal body and they don't have any regulatory power. So they can only put the message out to the state and territory WorkSafes, who equally I've spoken to as well, and they're very interested. And certainly a lot of WorkSafe inspectors have come and spoken to me and said, yes, we see this all the time, but they feel quite powerless, and particularly in Western Australia, I think we had about 6 WorkSafe inspectors. We're now down to about 2, so it's a shrinking area. But yes, so certainly they recognise that it's a problem, but I haven't heard about any legislation or even that they might be thinking about regulations or legislation.
Okay. Okay, I think I just have one question, final question possibly, and it was just to go back to the issue of climate change, and just thinking about the Pacific Islands and their resource poor, but the need to think about adaptation policies, and whilst we can advocate here, I'm just wondering how you see those countries responding or adapting when they've got more immediate concerns possibly.
Well, I can't speak for Pacific Island people, but I do know that many of them would say that climate change is actually one of their great concerns, in spite of all the other challenges that they face, and that is because of the way in which it's already impacting on their lives, both in terms of the rising sea levels, but also increased storms and the like. And, you know, they've also been very active in the international space in terms of the UNFCCC process in voicing both strong voice in terms of mitigation, but also calling for support in adaptation. And prior to the global financial crisis, I think particularly the European Union countries were actually supporting quite a bit of activity there. My understanding is that I don't think that's disappeared, but it has reduced subsequent to the global financial crisis. And I think, you know, that's where, and Australia is really a world leader in avoiding our obligations internationally. And, you know, it's quite extraordinary when we think about it, and I've been thinking about this, now I'm going to go on another hobby horse, thinking about this more and more in the context of climate change, that while we respond to climate change, both in terms of mitigation, hopefully, which will happen soon, but also adaptation, we need to be addressing critically the inequalities across the globe, both within our countries and externally, because unless we do, I don't think we're not going to be in a position where we'll reach a social and economic situation where we'll be able to achieve mitigation, but secondly, in the adaptation space. So, I mean, I suppose, you know, I'm probably asking something that's potentially unachievable in our current environment, but if we look at all the issues that we've been speaking about today, a lot of the migration, both climate and non-climate related, relates to global inequality. And, you know, unless we start to address global inequality in a real way, we're not going to be able to address any of those issues.
That seems to me a very poignant note to finish this session on, and unless there are any final burning questions that Okay. I'd like to thank our 4 speakers, the 3 in the room, and also Mark from participating late at night in the USA, and to thank the audience also for your participation, and questions have been very valuable. So thank you all for attending.